Um, thank you. Thank you so much for joining us today. Taking the time out of your busy schedule to attend asthma. I've my first slide. I've got some pictures of some famous celebrities. I think they're famous. So I'm sorry if you don't think that. But these are people with asthma who are living with it. So asthma doesn't choose you by your social class. It's just present there. The thing that's different is the our social class that would determine is the outcome of what happens to these individuals. And it is a subject that was quite, I was aware that, asthma is a serious condition, causes deaths, and can be fatal. But just before the pandemic, I lost a dear friend. So we were in our mid-30s. I just had my daughter, and she was looking forward to motherhood. She wasn't a mother yet, but she was married. And it was quite a shock because she was admitted and she said, I don't know why they've kept me in. I feel fine. And 3 o'clock in the morning, she was gone. So that was quite a shake up call for me. So asthma, so I think it's brilliant that you guys are here today to increase your knowledge about asthma. So I hope that this is informative. If you've got any questions, please do ask. I'm happy to take the questions in between. So just raise your hand, and Yasmina will help me keep an eye on the chat and the hands. So our learning objective today is going to be to talk about asthma prevalence, the diagnosis of it, covering both NICE, SIGN, BTS, steps we can take to prevent death, strategies for management of chronic asthma, risk assessments, and the acute treatment of asthma exacerbations, and most importantly, the personalized asthma action plans. I'm not going to do this all by myself. And there is Suparna, who is a GP in Hornchurch, and she'll introduce herself fully later. She's one of our program directors locally. So she's an educator by background. And we've got Nishita, who's a pharmacist. So just in context, globally, it's about 339 million people. In UK, we have about 5.1 million people. It's about 1 in 12 adults and 1 in 11 children. UK still has the highest rates of asthma, both in Europe and in the world. Now we also have the highest death rate in Europe with asthma, and these are preventable deaths. So that's why I think a lot of emphasis has gone on to how to manage asthma. So especially the personalized action plans are very, very important to do for them. And there's a website for it, which has more than half of it is all filled. It tells them when to call 999. It tells them what to do. And you have to fill in their basic statistics in there, like their peak flow, or so they know when it goes abnormal, when to call which team to get help as quick as possible. So, just a question to everybody, that do you know what is the strongest risk factor for predicting a future attack? Do you know which asthmatics you would like to refer to secondary care? Do you know the gold standard test to diagnose asthma? What is the minimum number of respiratory objective tests you require for the diagnosis? What FEV1 would signify a positive, diagnosis? Do you know when can phenotesting be raised and still not be asthma? So hopefully in this presentation, I'm going to cover all these aspects. So asthma is a chronic condition, and it's characterized by airway inflammation and hyperresponsiveness to allergens that are there in the environment. It's a variable disease. So it varies on a day-to-day, on a weekly basis, monthly basis, and actually throughout their whole life. So we often see that we say to people like, oh, they've grown out of their asthma. And then just out of the blue, one day they get another asthma attack after like a decade, 2 decades, so it's variable. So acute exacerbations, they cause these variable airflow obstructions, and that gives us the wheezy noise, the musical noise that we get in asthma. And it's triggered by a range of environmental factors. And we can minimize these exacerbations if we provide them with good chronic disease management. And I think this is where we all as a team will make a difference. And it's brilliant to see a whole range of people here today. We've got care coordinators, we've got, social prescribers, we've got pharmacists, and we've got doctors and nurses. It's a beautiful mix of people. We can all make a big difference to this cohort of people. So overdiagnosis is common, but it doesn't mean, and it doesn't mean it's a good thing. Because we're over-treating, then we're treating people who actually don't have asthma, and giving them exposure to treatments like steroids, it does have side effects, especially if they're elderly. The anticholinergic workload on the patient, which can cause, I'm sorry I'm using jargons because this is like a bit more advanced webinar today. So there are some medications that have these lows, and we got a pharmacist later on, so you can tell me that I'm just talking rubbish. But elderly patients sometimes get a lot of side effects from inhalers, and steroids at high doses. Remember, they get side effects. So the diagnosis, as such, it depends if you want to use NICE or you want to use BTS or SIGN guidelines. I tend to stick to NICE guidelines because that's what we have grown up with. And the NICE guideline emphasizes we need to do objective tests to confirm the actual diagnosis. So we don't just use the history, especially a history of allergy alone, to diagnose. But BTS's SIGN has a different approach. So you do a history, you do a challenge, and then if the challenge doesn't work, you can go for spirometry, pheno testing, and stuff. So the two guidelines, causes confusion. Which one are you going to use? So you can just stick to one, and which one works for you, and you can do. So in the future, both of them will be are developing the guideline together. So it will be jointly produced. So yeah, so it is basically the BTS SIGN guidelines recommends a structured clinical assessment based on history examination. Then you review the history of variability, and then you class them as a low probability, intermediate, or high. And depending on which box they are in, you give them that treatment. And there's a chart for it, and I will share it with you later on. So you can. I think I haven't got the BTS SIGN one, but I've put down the NICE one because I thought I'll just like to stick to NICE. But maybe Suparna will later on take you through the management. So the NICE guideline says you do so you have people that you suspect they have asthma. So the symptoms will be wheeze, cough, breathlessness, or chest tightness. It will be daily, or there'll be seasonal variations. There'll be triggers that make the symptoms worse. And there might be a personal history of, allergies or asthma in them. So you would do a spirometry with pheno testing for those. Now, if somebody has acute symptoms on the first presentation, then it does recommend treating them, start them with some treatment straight away. If you're not sure, after you've done the spirometry, then you can still use the peak flow variability over 2 to 4 weeks. So get enough data so you can actually see the variation during the day of the peak flow readings, which will, help you see. So I've put down the chart there, which is for NICE guideline, which actually tells you where they would, where do they sit, like how to follow it. So this algorithm, this is algorithm A, and it covers under 5, between 5 and 16, and like 5 to 16, not between, and then over 17 years old. So under 5, you would just treat them based on the symptoms and observations and clinical judgment. But if they're between 5 and 16, they can you can do spirometry tests and pheno testing on them. And then over 17 as well, you would do the there's an algorithm for that, which I will take you through in a bit. So this is the algorithm B for children between 5 and 17. So you do the spirometry, it shows an obstruction, it will be yes or no. And the pheno level for them is 35. Yeah, so the improvement with the bronchodilator reversibility should be about 12% or more. So you would basically, and the peak flow variation, you're also looking for a 20% variation in them. If you still feel you're not sure, you can always send them to a specialist to get a confirmation of the diagnosis. Now in adults, it's the same one. It looks a bit more complicated, but once you get the hang of it, it's quite simple. So people with symptoms, you'll be sending them off for a spirometry. If they have acute symptoms, you'll be treating them as you whilst they're waiting for the test. So the ones that you've sent off for the test, so it will either show there's obstruction or there isn't. I think obstruction is if the ratio FEV1 FVC is less than 70%. So that's your number for the obstruction picture. Pheno testing will also be done on the same day, so it should be at least 40. Can be more. So that just means there's eosinophils. Now, pheno, I'll talk about pheno in a bit. So they also look for the reversibility. So they want to look for at least 12%. It's roughly about 200, I think. Yeah, in the score, but they're 200 mils for adults. So yeah, it's all there on the chart. And the p-flow variability as well, if you're looking for that, then it's 20% variability. Now, if this is unequivocal, it's just borderline or something, and you're still not sure, you can send them to the specialist and they can do further testing. There's some more tests like the histamine methacholine test that can actually do a direct bronchial challenge test, and they can tell if this is asthma or not. Now, pheno does not go up in COPD, so this helps to actually get a distinction between those overlaps. So pheno, it stands for fractional exhaled nitric oxide, and the NICE recommends doing this test to diagnose. So there are figures for each area. So it indicates whether there's eosinophil inflammation in the lungs. So eosinophils, they're released when there's some form of allergy. It's just there in the blood. Some specialists, they actually look at the eosinophil levels in the FBC, and then they decide whether what treatment they're going to have. So it does support the diagnosis, but it doesn't conclude it. So it can be raised in lots of things, especially so yeah, so what I was going to say was that COPD doesn't raise it. It can be raised in men, in tall people, especially if their diets are rich in nitrates, if they've got allergic rhinitis, because eosinophils go up in that as well. If there's a coexisting rhinovirus infection, so that's why we would recommend doing a spirometry at least 6 to 8 weeks after an acute exacerbation, so that you've given the person chance to actually recover and then do it. So there can be decreased levels in smokers or people who are on inhaled steroids already. So that's the dilemma, where if you're treating them before they actually go and do the spirometry, there is this chance that the levels will be different. But we just have to do the best for the patient, so, and then pick things up later. So I thought I'll put pictures of these. What are any thoughts on who these are or why I've put them up? You can unmute yourself and tell me, or you can write it in the chat. You can see there's about 10. I can see Kim said we use BTS sign. Yeah, RCGP follows NICE. Sorry, Kim. But it's both of them are acceptable, so you can use BTS or sign if you want to. And I know RESP use it. So Kim is our pharmacist in my PCN, and she is brilliant. She's got masters in respiratory, so she comes and teaches us everything. So she knows the stuff. I'm just trying to see. So I'm just checking if anyone's realized. Thank you, Kim. Well, these are people who actually died of an asthma attack. So that's why, but they're famous people. I don't know if anyone can recognize the old man in, you know who that is. Don't worry if you don't. He's the eighth president of USA, and the black and white one is an Indian actor, and the man with the phone is also an actor. So they died of an asthma. So I just thought bring you to preventing deaths with common themes. So the common themes that the coroners have found is that the tests haven't been done to diagnose asthma. There's over-reliance on preventive treatments, insufficient preventive treatments there as well, one of the reasons. Then a lack of education in patients. So 27% who died, only 27% who died had PAAPs. So failure to recognize the risk in patients who've had a previous attack. So that is the most important risk factor in predicting a future attack. What it recommends is that we code people as suspected asthma before the diagnosis, and then we change it to asthma once we've got the when we've got the diagnosis made. So, assessing future risk for asthma, having a previous asthma attack is the strongest risk factor. So you perform a post-asthma attack review at 48 hours to see if it's resolved, if it needs modifying treatment. It allows you to also have that opportunity to spend with them to do health promotion, that are associated with poor outcomes like smoking. And then it gives you a chance to actually check if they've actually had an objective assessment of their asthma. Quite a lot of patients have just been diagnosed with asthma and I'm sure they have asthma, but they haven't had a spirometry done. Okay. I just thought I'll just share this ACT score, which is what these are the 5 questions in an ACT score, and you get a point. So when they say, if it's there all the time, like the green one that I've selected, that means they've got 5 points, and that means it's a very poorly controlled asthma. So then number 2 will have 2 points, and then the third answer is 3 points. So then you calculate it, and then the maximum someone can get is 25. And 25 means it's well controlled. So it depends where on the spectrum they are. And this is part of the QOF. It's on your EMIS template, so you can calculate this and do it. You can send Accurex messages if you use Accurex to get these scoring in. Thank you. So that's the end of my section. I'll hand over to Suparna. I'll stop sharing my sharing.
Sorry, Uzma.
Yeah.
There were just, I think you answered Kim's comment.
Did Kim have a question, or was it more
there
like...
was, oh, actually, it was both Kim. Okay,
comment
about BTS, Sign, and Gina. Okay, I think you answered that.
I think that was more she was mentioning.
Sorry. Okay.
More a comment, I think. But yeah, feel free to ask questions if you have. You can write it in the chat. Have I stopped sharing? Yeah.
No, it's still sharing.
Oh yeah, stop. Thanks.
Perfect.
Thank you, everyone.
Thank you so much, Uzma. Suparna, over to you.
Yes, I'm just going to see if I can share my screen, and then I'll start. Again, I can't see the chat, and neither can I see anyone.
I'll keep an eye on the chat and I'll update
don't worry,
you.
We'll help you. Yeah.
Yes.
Okay, thank you very much. So thank you, Usma. That was really good. And I'm Suparna Chakrabarti. I am a GP in Rumford. I'm also the training program director at our GP VTS training scheme. And it's really good to see so many people here. So we've already discussed about the diagnosis of asthma. And I think there was a bit of an issue which guidelines we use. NICE, SIGN, BTS. Obviously, there are different ones. But as far as I understand, NICE and SIGN came to an agreement with BTS, and they have done a joint guidelines from December 2021. So maybe they have probably hopefully merged some of their things, and that might just be same now. However, I think NICE discusses a bit about the structured questioning around diagnosis of asthma, especially I think in children. It is difficult to diagnose asthma because there are so many other issues that can cause the same thing, same symptoms, like viral wheeze in children, especially children less than 5. And the sign guidelines suggest some probability factors, like factors which have high probability towards diagnosis of asthma and factors which have low probability of diagnosis. So that's something maybe to think about when you are diagnosing asthma. So as GPs, we do use different guidelines. The treatment or management is based on NICE guidelines that we're going to discuss here today. I think the sign guidelines are similar, but if there is any difference, please feel free to share it and then we can have a discussion. So first thing really is to start treatment at the appropriate level of severity. So if someone has got quite severe symptoms of asthma and you're just thinking of giving them some salbutamol inhalers to try, that is not really a great idea. So if the severity is a bit more, then obviously better to start probably with an inhaled steroid, corticosteroid as well. The low, moderate against higher dose. Obviously, we don't go that much to higher dose, but the low and or moderate dose will depend on the severity that they present with. So it's important to think about starting at appropriate level of severity instead of just giving everyone SABA, which is a short-acting beta agonist, first. So to think about the severity and then start at that level. However, in most cases, if they have got sort of minimum symptoms and we're still thinking whether this is asthma or not, we need to do all the investigations that we have to do to come to the diagnosis. You can try a short-acting beta-2 agonist, which is most of the time salbutamol. Terbutaline can be used as well if there are anyone who is allergic to salbutamol. But it should also be given to people diagnosed with asthma to use as a reliever. But the most important thing is, again, education and educating people that this blue inhaler is a reliever. It doesn't,
Sorry, Suparna.
asthma. Yeah, sorry.
You're still on the first page.
Has it not moved?
No.
Okay,
Why don't you just click next or go down second slide? Yeah, that's great. Thank you.
I can see the second slide, so I'm just going to then stop once more and reshare because it may be that
now I could see the second slide, but the whole time you were talking there, it was just on the first slide.
Okay.
So if you just press next, or if you go down the next page each time.
Is the screen still being shared? Because I can't see the screen now.
I think you stopped sharing.
Yeah, okay. Just give me 1 minute. Sorry, I've lost my slides. Okay, I'm going to try and share again.
I think while Suparna's doing that, there's a question asking if getting frequent coughs and colds in children with wheeze, does that mean that they have asthma? So we'll pick that up in a bit. Okay, Suparna, sorry.
Okay, do you want me to answer that now or do you want to?
If it's possible, thanks.
Okay. So children get very recurrent coughs and colds and they wheeze with their cough and cold, and most common reason for that is because their air passages are narrow and any sort of respiratory viruses or infections makes it even more narrower and therefore they wheeze. And so therefore we can't just assume that if they are having wheezing during a viral illness or during an infection, whether it is viral induced wheeze or whether it is asthma. And maybe in those cases, it's important to see if they are wheezing in between when they don't have a viral illness. But again, if they're needing steroids to control this wheezing during these viral illnesses, then I think maybe we need to consider that they may have got asthma. I hope this answers the question. Can you see the slides at all?
I can see just the number 1, just asthma management in primary care.
Okay.
Now
What
number
about,
2, yeah,
you
nice,
can see
nice.
the number 2.
Yeah.
I'll just leave it like this because I think if I go on to slideshow, it's for some reason it's just not
Okay.
picking up. Is that all right?
Absolutely, yes.
Okay. So basically, when someone's using a SABA, which is a short-acting beta-2 agonist, if they have a good control of their asthma, they should use very little SABA. So a way to monitor that is to look at the prescriptions and how many prescriptions they're having in a month. So if they're needing to have really more than one prescription of SABA in a month, then maybe they need to have an asthma review and a review of how their control is. So when do we then go on to the next step, which is inhaled corticosteroids, obviously? Few things to look at. If they're using SABA more than 3 times a week, if they have asthma symptoms 3 times a week or more, if they're waking up at night with asthma symptoms once a week or more, here it probably answers a bit of that question. So in adult or children more than 5 years who've had an asthma attack needing oral steroids in the last 2 years, then we need to think that they need to go on inhaled corticosteroids. So once you've decided to go on the inhaled corticosteroid, we need to start at the lower end of the dose for each age group, which the BNF will tell you, which the NICE or SIGN guidelines will tell you. Again, the dose also depends on which preparation to use. So you have our brilliant pharmacists who can help you with that. There are so many different types of preparations now. It does get a bit confusing, but I think the dose varies, like the dose of Clenil varies with generic beclomethasone. So I think and QVAR. So we need to look at which one we are using. And also remember that if someone is a smoker or an ex-smoker, they have reduced effectiveness to the inhaled corticosteroid, so they need higher doses than than others. Again, just a bit about inhaled corticosteroids. Usually, you would start them at twice a day, and once they have used it for twice a day for a few months, you've seen that they have got good control, which means they're not needing to use the blue inhaler that much. Then you can decrease the dose and bring it down to a once daily maintenance dose, so that you're not exposing people to too much steroids. Just checking that you can still see my slides, okay?
Yes, yes, we can see your slides. Thank you.
Okay, great. Right, so once you've gone on to, obviously, inhaled corticosteroid low dose is step 2. And once you've gone on to step 2, if their symptoms are persisting, or if they come back and say, well, I've still got symptoms, it's not improving, then I think really important to go back and review things again before you change treatment or before you go ahead and go up the step or increase the dose of the steroid or go up to higher steroid. So check compliance to treatment, make sure they've understood. I have spoken to so many people, and many people don't understand that they need to use the brown inhaler regularly, or once they're better, they feel it's fine and they stop it completely. They haven't really had a discussion about what level of maintenance dose that they can continue with. Majority of the people really use the blue inhaler most of the time. So I think there is a lot of importance in education and making sure that they're compliant with their treatment. Inhaler technique is something else to discuss as well, and making sure that we are checking it. I think once when Nishita is going to talk a bit about some of the therapies, and I will ask her if it's possible to discuss a bit about the inhaler technique at that time, or signpost you to different websites that there is, or YouTube videos that you can use to demonstrate the inhaler techniques. Again, trigger factors are important. Are people smoking? Are they using a lot of perfumes? Are they allergic to house dust mite? Then it's difficult to control house dust mite and pollens, those kind of things. They are unavoidable triggers, but they can minimize those. And maybe in some cases there may be some food which triggers asthma, and if that is there, then maybe just thinking about that and how to avoid that. Then obviously you consider a trial of an add-on therapy. I just want to say very briefly about e-cigarettes or vaping or electronic cigarettes and their effect on asthma. Really, the reason being, this lots of people are using that as obviously to help them to stop smoking, but there has been some evidence or research showing lots of younger adults or adolescents have taken up vaping as a, like people took up smoking. So it is a new model of smoking in adolescents and young adults, and we need to be aware of that, because originally it was used as or marketed as an aid to smoking cessation, but it has been seen through different researches that lung function does deteriorate with use of electronic cigarettes in patients with asthma, and it can worsen asthma symptoms, its rates, and its severity of exacerbations. It contains various toxic components which can cause more inflammation and induce obviously respiratory morbidity. So just be aware of electronic cigarette. Most of my information on this page is from GP Notebook, which I do use quite often. So other add-on therapies that we can use for adults. So the first one to look at, the LTRA, is the leukotriene receptor antagonist, and we know it by the name of Montelukast. It is taken. So here I'm talking about adults over the age of 17. And you can take that once at night. So you can try this one, or you can try a long-acting beta agonist with a combination with the low-dose ICS. So you can use one combination inhaler for that and use that as the first option, or you can use the Montelukast as the first option. If after using either of these for 4 to 6 weeks and the symptoms haven't controlled, then you can try the other one. The main decision is whether to stop the one that you've tried, or continue with it and add on, is obviously a clinical a judgment, discussion with the patient to see what amount of improvement they had with that, and whether they're willing to, how many therapies they're willing to take. So then another option here is that if there is no improvement with the low dose ICS and LABA and plus minus the Montelukast, then you can consider the MART regime. And in the MART regime, you use a fast-acting LABA and not a slow-acting LABA, because that SMART regime can be used both as a reliever and as a preventive therapy, so as a maintenance and as relief of symptom. Formoterol is faster acting and is licensed for use for MART, whereas salmeterol has got slow onset of action, so it's not licensed for MART. I wonder maybe if Nishita, you want to do your presentation on MART and inhaler techniques at this time?
Yeah, that'd be great. Thank you,
Okay.
Sabrina.
So before you start, I'd just say that, for further add-on therapies would be increasing to moderate dose ICS or LABA, and then considering high dose ICS and LABA. However, and other things like theophylline and oral steroids. But at this stage, you're really thinking then that you need a referral to the specialist team, and then, looking at from that side. So I think once you've crossed the moderate dose and you are near the higher, thinking of the higher dose, you should probably referral to the specialist team would be useful. So I've stopped sharing now. Have I
Suparna,
stopped?
sorry, Nishita, I just wanted to ask something to Suparna. There was a question posed by someone, by a Diane Blade earlier, and she said, I was under the impression from recent study days, we are trying to move away from loan, ICS, and SABA for smart, MART, or air therapy for better
That's correct.
control and reduction in cost. Is this correct?
Yes,
I'm
that's right.
sorry, can I check that question? So we're not, so the question is saying that we shouldn't use, or we shouldn't be using MART therapy because of cost purposes.
No, what she's saying is that we should be moving towards smart therapy, and that's what's advised
Or
that we use.
instead of that, yes, I think that's absolutely right. And if your patient is able to do that and understand that that is their reliever as well as their maintenance therapy, then yeah, that that is something you can definitely try when you are coming to that stage of where you need a LABA and a ICS. Definitely, I'll let you get on, Nishita.
Nishita, is it okay? I don't know if someone can take this question. Somebody has just posed a question. Nemo, it's the last one just now. I wonder if it's to do with what it was just been said.
Sorry, can you read the question? Because
Of course.
Nemo, is
Okay.
one that they've used the SABA for 3 months, that we can reduce the low dose ICS dose to OD. If they have used, yes. So I think you have to see how their control is. There is no cutoff time, 3 months, or if it needs them 6 months, you take 6 months. So it's very difficult to just give you a cutoff time, but it will also depend. It will all depend on what their symptoms are really and how well they're managing. So if after 3 months they have not used their SABA, even maybe used it once or twice, and they haven't got any of the other symptoms that would indicate that they're not well controlled, then yes, you can cut down the dose and try. So try on the low dose ICS. And if they're starting to get the symptoms back again, then they'll have to just go back a step up. I hope that answers the question.
Thank you very much. Do go ahead, Nishita. Sorry. Thank you so much.
No worries. Hi there, everyone. My name's Nishita. I'm a PCN pharmacist. So I'm going to be talking to you today about MART therapy. So if I can just share my screen with you there. And I can't see the screen, but is it working?
Yes, it is.
Brilliant. I'm going to try and see if I can play it. For some reason, I've got the same problem. I can't play it, but I will go through it. So starting with MART therapy, I'm just going to go through it just for people, people who might not know what MART therapy is and when it's used. So MART is a type of asthma treatment used when we just use a preventer and a reliever, which is one inhaler. So basically, you don't use it separately. It's one inhaler and it's a preventer and a reliever. It can be considered for patients with inadequate asthma control and a frequent need of a reliever medication. Someone who has asthma exacerbations in the past are requiring medical intervention. Patients must have received education on the use of the inhaler, because it's very important that they actually understand how MART therapy works. Because a lot of patients I've personally reviewed feel like they still use, for example, Duorest, which is part of the MART therapy inhaler. They still want to use their Ventolin inhaler alongside that. So you need to actually educate the patients to ensure that they actually understand how MART therapy works. Also, patients should be advised to always use their inhaler and available for rescue as well. So it should be always carried away with them. Patients requiring frequent use of rescue inhalers should be advised to return to the GP practice for review again. The next slide. Okay, when considering switching anyone to MART therapy, there's things that you should definitely consider. One of the main things is that inspiratory capacity of the patient, because of the fact that if they can't use the inhaler correctly, no matter what therapy we use with them, it's not going to work. So using an in-check device is always advisable. Making sure they can actually the inhaler is correct for them. Manual dexterity, sight. Trying different inhalers with you. You should actually have in practices different inhalers you can go through with the patient. That should actually help in deciding if it's suitable for that patient. And it's obviously care with the elderly and children under 12 and the mental capacity of the patient to actually understand how to use that inhaler. There is a few licensed inhalers for MART therapy out there currently. These are the well-known brands that were actually established earlier on for MART therapy. So we've got Foster, Nexhaler 100 by 6, which is licensed for use in over 18s, and it's 1 to 2 puffs twice a day. And additional puffs are required for MART therapy, so a maximum of 8 puffs in total. We've got COPD guidelines there at the end as well. We've also got Symbicort 100 by 6, licensed for children in from 6 years, and it's 1 to 2 puffs twice a day, also for MART, and up to 8 to 12 puffs in a day. We've got Symbicort 200 by 6 also, and that's 1 to 2 puffs twice a day for MART, and up to 8 puffs a day in the whole day. And then we've got Duorest 160 by 4.5, and also same sort of guidelines in terms of 1 to 2 puffs and maximum 8 puffs in a day if needed. There are other brands now available, which practices are now trying to switch patients to for cost reasons. Always make sure you talk to the patient before switching these patients, like the Fobumix, Lufrobec, and the Vocair, because I think we're doing a lot of work on switching patients to Lufrobec at the moment. But it's vital you talk to your patient to ensure that they know that you're going to be switching them, and it's an equivalent inhaler.
I don't know,
Also,
Nishita, if you want to answer the question now or later. Just Cynthia said that Foster 2 puffs twice a day is not licensed as per
yeah,
BMJ.
that's right. Yeah, so 200 by 6, 2 puffs twice a day is not licensed. In 100 by 6, it's licensed as 2 puffs twice a day. I think that's correct. I can double check, but I'll come back to you on that one. So yeah. Next slide. So like I was just going to mention, here it is. So which inhalers are not suitable? So important to know that Foster 200 by 6 and Lufrobec 200 by 6 are not suitable, as well as a Duorest 320 by 9 is also not suitable. So it's always best to check which inhalers are suitable for MART therapy, even though you'd think, the Foster 100 by 6, you can increase the dose to a certain point and then it's suitable for MART. It might not be. So I normally use a website called Right Breathe, and it also has inhaler techniques on there as well. So it's really essential that if you haven't got the inhaler in practice to show a patient how to use it, you can go to this website. It tells you, if it's suitable for MART therapy. It also tells you how to use the inhaler. I don't know if I can stop sharing this screen and I can actually show you. For those of you who have never used that website, would it be useful? If they want me to, I can just send the link to the website. I don't mind, but I can't see the chat, so if they want me to show them, I can do. Anybody want me to show them, or I can send the link?
I'll happily send the link afterwards, after the meeting, to all the attendees.
Okay, brilliant. That's
if
fine.
you send it to me. Thank you.
Yeah. Okay, so take-home messages: change patients where possible to MART therapy, but do not switch without a review. Ensure sufficient inspiration rate. Patients can use it, and some patients MDI is best, so it's not always suitable for all patients. All right, I'm going to refer you back to Suparna there.
If you just look at the chat, Nishita, there's another
I
question.
can't see the chat. If I can
Oh,
just.
okay. If you stop sharing, have you finished?
Yes, I've finished. Yeah.
So if you stop sharing, you'll see in the chat there's Kim, who has written something.
Let me just stop sharing this screen. For some reason, my screen is frozen. I can't seem to stop sharing this.
I can stop you from sharing.
Yeah, that'd be great.
There we are.
Does it come back?
There you go.
Oh, brilliant. Thank you, Yasmina.
There we are. No problem. It's from Kim.
Okay, let me scroll down. Can I see? Is it this one? In now, for patients
Yes.
using MART, we are advised to issue 1 Salamol with a spacer purely for admission avoidance during a serious exacerbation. Otherwise, we use the 1 inhaler for shortness in breath. Okay, so was she? I think Kim, if what I can understand from what you're saying is that you're allowed to prescribe the Salamol alongside MART therapy. But is there a criteria for the patients that you prescribe for? Is it just patients have exacerbations? I know in COPD, obviously that's something that we do anyway, but in asthmatic patients, we're not doing that in our area. But
I don't know if Kim, you want to come off mute and
yeah.
We'd love to hear your voice.
Yes, please share your wealth of knowledge.
Oh, she doesn't have a
She
microphone.
hasn't got a
Okay.
microphone.
She doesn't have a microphone.
No,
Okay.
so we don't give it to everybody in March, so I don't know about that.
Oh, it was very funny. We have another question from Diane.
What about air therapy? Symbicort no license from A12 up to nation a day.
So
Sure.
do you want to look at the question, Nishita, and then let me just progress, and then you can answer it afterwards? Is that
Yeah,
all
that'd be
right?
great. Yeah, that I can
Yeah,
answer them while
because
you're going on.
otherwise,
Yeah, please do.
okay. So just very briefly on children. Again, you are either starting with SABA or you are starting at low dose ICS and SABA. Then after that, it's really what NICE is saying is to try the Montelukast first before you try the LABA. So that's just something to think about. And, because in adults, you can try LABA or LTRA, but in children, it's better to try the LTRA first. And then at that stage, if you're thinking of increasing it to moderate fixed dose ICS and LABA, I think we need to think about then referring to the pediatricians for review. Just very quickly and briefly, we're just going to touch on asthma review. Obviously, we know the importance of that because it improves outcome and patient safety. It gives them an opportunity to discuss their asthma, impact on their life, and you can monitor the treatment. You can check, what they're doing. So how often? We in general practice, we do obviously do it annually, which is a structured review, and we should actually review them after every attack they have. And during the review, important things to think about is their current symptom control, their risk of future asthma attacks, what tests or investigations have they had, or do they need any, then the management they're having at this moment, and how do we support self-management. Again, to discuss symptom control, Usma's already mentioned about the ACTS questionnaires. So you can use that. You can send that through the AccuRx system, and those are the questions that we discussed already, and the results. That if it is sort of above 20, it's well controlled. Again, the same in children. Sorry, the C got lost somewhere. In those reviews, you're also assessing what is the risk of future asthma attacks. Obviously, you're looking at how often they've had past attacks, how many times have they used oral corticosteroids, how often they're using a SABA, how frequent prescriptions, and how infrequently is ICS being used. So how some patients might come and say, well, I'm using it regularly, but you can see that they've only requested one ICS in 3 months. So that really shows that they're not using it regularly. Exposure to tobacco smoke as well is something to think about. We discussed about inhaler techniques, discussed about adherence, and check that. Trigger avoidance, breathing exercises are important things to discuss. Then also in terms of the pharmacological management, providing education, discussing self-management, providing written asthma action plans. I'm not going to go through this because you all know this, the risk, what denotes poor asthma control, and what things to look at. Just want to show you the PAP. You also I'm sure you've seen the PAP. So this is the PAP where it tells them, what preventer inhaler they're using, when do they need to take it, how many puffs, the reliever inhaler they're using, how often, how much they should take, how many puffs, when should they take it, what to do when they feel worse, and obviously what to do when they have the asthma attack. These are the asthma action plans. So very quickly and briefly on acute asthma attacks and how we manage them in primary care. So all attacks in primary care are considered serious, obviously, or all asthma attacks are serious. Assessments, when we do it, obviously need to go through, determine their severity and classify if they are, just mild, moderate, or severe. we would look at mostly doing these things. So are they able to speak in full sentences? What is their heart rate, their respiratory rate, their oxygen saturation? And if they can do a peak flow, then what is their peak flow at the time of the attack? Now, ideally, I mean, all asthma attacks are a clinical emergency, and each and every one we need to think that could become potentially life threatening if something is not done. And though we really don't want to send them to A&E, but always think about patient safety. So if they are really severe, then they should go to the hospital. If obviously you think they can manage at home, then you can think about what you can do. So they can use high dose bronchodilators, the MDI through spacer, or if you can give them a nebulizer at the surgery. Some patients have got nebulizers at home which they can use, but you shouldn't really recommend them having nebulizers at home because of safety issues. They can use up to 10 puffs at a time when they are using it for an acute attack. You can give them oral steroids. Make sure you give adequate dose. So in an adult, it's about 40 to 50 milligram once a day, and the length is about 5 days. And in children, less than 12, it's 1 to 2 milligrams per kilo once a day, and for 3 days. If they're not on inhaled corticosteroid, please start them on inhaled corticosteroid at that time. Obviously, if they're needing oxygen, we can give them for a brief period at the surgery, but I think we would need to send them to hospital, probably call an ambulance at that stage.
Sorry, Suparna.
Yeah.
Sorry, there is a question from Diane Blade. And after this, we will have to wrap it up, I'm afraid. I'm very conscious of time. I really do apologize, but it's supposed to finish at about 3 minutes. The question from Diane is, sorry, I thought no nebulizers. Should it be oxygen driven now?
Yes, we shouldn't really be giving nebulizers because we can use the spacer and give the high dose bronchodilators through there. We can use 10 puffs. But in GP practices, obviously, it should be driven by oxygen. But we have some nebulizers in our GP practices because we sometimes give it to COPD patients in the practice where we shouldn't be giving oxygen to every COPD patient. But I think, yes, you're correct that nebulizers shouldn't be used, randomly just like that. And it should be driven by oxygen, especially when given to people with asthma. So I won't go any more on this, but we all know that they should be reviewed soon, really within a couple of days. And if they had gone to hospital, then we should have a discharge letter if they had attended. And if they have been into hospital and admitted, they should really be seen in a month's time by the specialist hospital asthma nurse or by the respiratory physician or pediatricians in children. I had some case studies, just some question and answers, but I think we are running out of time, so I will end it there and take any questions if you have anything that you want to discuss.
Thank you so much, Suparna. For all of you who have asked, I have had a few personal questions about whether the slides could be passed on to you. I will speak to the educators after this session and determine whether that's possible or not. In any case, this meeting is being recorded, which will be uploaded on our website. Do contact me if you need the link for the website so you can see the recording. It'll be put up from next week. Please as well, I have put in a form for the survey, just about 4 questions, yes or no answers, multiple choice with your name. And if you answer the survey, you get a certificate. There's another question from Kim, actually, Suparna, if you look at the chat.
I think Kim has answered the question. She said yes.
Oh, sorry, I'm sorry.
Okay. For asthma and in A&E and not
Okay.
oxygen driven for COPD. Yeah, thank you.
Thank you, Kim. Kim's my resident asthma expert. She's just brilliant. I can't, praise her anymore. She's really brilliant. I wish she had a microphone.
I think there's a question for Nishita. Nishita's slide says Foster isn't appropriate for MART. Which slide was that? And can you answer that at all?
Sorry, let me just go back to my slide. What is it? Foster isn't appropriate.
Yeah, that's what someone said here.
I think I put down Foster 200/6 isn't appropriate to be prescribed for MART, not Foster in general 100/6. I hope that clarifies that.
Okay.
Thank you, everyone. Thank you, Manasa. Thank you for all your lovely comments. And I really do apologize about the technical glitch. It is Zoom, unfortunately, that has suddenly decided not to accept the link that was there from the beginning. So thank you again for your patience and still making it our most populous yet. So thank you very much, everybody. We hope to see you at the T3 webinar. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Please do fill in that form. 3 minutes. No, it's not 3 minutes. Sorry, 30 seconds. 30 seconds. Thank you, Ebru. Take care. See you soon. Okay, so a lot of people. Excellent. I will stop recording.